pleasure today to accept this kind of invitation to share in this activity the 7th program, ambassador program for nephrologists at the Africa. Today I will deliver a presentation titled Histopathology of renal diseases. دكتور أحمد هو
نعم ايوه مع حضرتك. ايوه دكتوره منى انا سامعك.
الو ايوه دكتور احمد معلش هو في عندي بس مسج كده على يعني جايه اوفرلاب على السلايد كده في النص، هو كاتب this meeting is being recorded by the host or a participant got it ولا leave meeting ولا ايه؟ عشان هي عندي على السكرين فمش شايفه السلايد. got it عليها دي ازرق والثانيه leave meeting يعني اترك الميتنج. got it تمام ماشي شكرا. تمام ماشي تمام. السلام عليكم ورحمة الله. It's my pleasure today to share the activity of the 7th program of ISN Ambassador at Africa. And today I will deliver a talk titled Histopathology of Renal Disease. In the kidney, we have the usual four histological structure: glomeruli, tubules, interstitium, and the blood vessels. And this photo demonstrating the four structure. This is slide stand for pass stain, and we can show here the glomerulus in the middle of the section, and this is the glomerular capillaries in the inside, and all the other rounded structure are the renal tubules with nice basement membrane delineated by the pass stain, and at the upper side here is the section in two arches. And here we revise major clinical syndrome of the renal diseases, which are acute nephritic syndrome, nephrotic syndrome, asymptomatic hematuria or proteinuria, rapidly progressive glomerulonephritis, acute renal failure, chronic renal failure, urinary tract infection, and nephrolithiasis. Glomerular syndrome and disorders, the nephrotic syndrome starting for the glomerular syndromes and disorder by the nephrotic syndrome. Among many causes that presented clinically by nephrotic syndrome, I choose this more common histological forms. First and second, minimal change and focal segmental glomerulosclerosis, membranous glomerulopathy, and membranoproliferative glomerulonephritis. The nephrotic syndrome, minimal change disease. Minimal change disease is a major cause of idiopathic nephrotic syndrome, and pathologically is a glomerular disease with minimal or no glomerular alteration by light microscopy, with no glomerular immune deposit, and the only abnormality that experienced in this disease is the extensive food process effacement at the electron microscopy. By light microscope, typically the glomeruli display little or no histological abnormalities. Glomerular capillary are fully patent. A minority of cases, there is mesangial prominence. The glomerular plasma membrane appear normal in thickness, texture, and contour. Like in this photo here, this photo show two glomeruli with patent capillary tuft and no mesangial increase and no hypercellularity, and the tubules show normal configuration. Also here a section in arterial wall and also within average finding. This is high power magnification, light microscope, and this is a glomerulus situated at the middle. And we have a very nice glomerular basement membrane, and the capillary tufts are patent, and no mesangial expansion or mesangial cell increase or any abnormality. For the immunofluorescence, absence of detectable glomerular immune deposit, minority may exhibited weak mesangial deposit of IgM. The tubules show diffuse positivity for albumin in the distribution of proximal tubular cell protein resorption droplets. Electron microscopy finding. I will not describe the electron microscopy as there is in the schedule a special lecture for electron microscopy, so I will not show any electron microscopy in this talk. Second item responsible for nephrotic syndrome, which is one of the commonest histological types, is the focal segmental glomerulosclerosis. The light microscopy finding of FSGS or focal segmental glomerulosclerosis is just a description of the name of the disease, which we can find discrete segmental solidification of the glomerular tuft. Early in the disease, segmental lesions have a predilection for the juxtamedullary glomeruli, the anatomical site that is juxtamedullary between the cortex and the middle. A lesion may involve perihilar region where the vascular pool lie, or it may be involved with the other side, periphery of the tuft. Some glomeruli have segmental lesion in more than one lobule, involving both perihilar and peripheral lobule. Glomerular capillary are segmentally occluded by a cellular matrix material often associated with, like here in this photo, this is a section in the glomerulus, and here the capillary tuft is patent, like the minimally changed disease. But here we can show that the glomerulus is observed for or remarkable for this segment of sclerosis and mesangial expansion here and sclerosis. Also here there is early segmental mesangial expansion also here. This section is stained by Mason trichrome, and here this glomerulus, and this is the hilar pole where the afferent and efferent arteriole lies, and on the other side, the periphery of the shaft, we have noticed a segmental sclerotic lesion that have Mason trichrome positive in the blue color, and this segment of sclerosis with adherent to the capsule of the glomerulus and making obstruction to the urinary space. The urinary space is patent all over here and all over here, but it is interrupted at this site. And this is another glomerulus in the field where here is the urinary space is patent, is not interrupted by or occluded by the segmental sclerotic patch. Immunofluorescence. Also in focal segmental, the immunofluorescence was not significant. Few cases may showing exhibited segmental granular deposit of IgM or C3 in the distribution of the segmental sclerotic segment or hyalinosis. Just this. This is immunofluorescence for IgM for one of the cases. This is the sclerotic segment at the periphery that interrupted the urinary space, and it's showing positive staining for IgM in immunofluorescence microscopy. Next morphological item for nephrotic syndrome now is the membranous glomerulopathy. Primary membranous glomerulopathy, a spectrum of glomerular capillary wall abnormalities resulting from the formation of subepithelial deposit. Light microscope, the only finding that we notice for light microscope is glomerular capillary wall thickening seen in fully developed forms of the disease, and this is not associated with mesangial expansion, cellularity, or any abnormal, just thickening of the basement membrane. And primary membranous glomerulopathy is very unlikely, and the most common is the secondary membranous glomerulopathy. And we have a lot of conditions that associated with membranous glomerulopathy. First group of diseases in the etiology of secondary membranous glomerulopathy, we have first autoimmune or collagen vascular disease, and under this title lie systemic lupus erythematosus, rheumatoid arthritis, mixed connective tissue disease, Sjögren syndrome, autoimmune thyroiditis, primary biliary cirrhosis, ankylosing spondylitis, and Crohn's disease. Second etiological group is the infection group, and here lie hepatitis B, hepatitis C, schistosomiasis, malaria, or filariase. Next group of etiological agent for membranous, secondary membranous glomerulopathy, we have many medication cause this membranous glomerulopathy. Among them, we have penicillamine, gold salts, trimethadione, or bucellamine. Also, it's very common association of membranous glomerulopathy with neoplasms. Malignancy is a common association for membranous, like visceral organ, like colon, lung, breast, stomach, pancreas, any carcinoma is very common association. Also, other like melanoma, Wilms tumor, lymphocytic leukemia, Hodgkin disease, and non-Hodgkin lymphoma as well. Also still have another etiological agent for membranous glomerulopathy. In the miscellaneous group, there was sarcoidosis, can cause membranous glomerulopathy, sickle cell disease, Guillain-Barré syndrome, angiofollicular lymph node hyperplasia is known as Castleman disease. And this is the light microscopy of the membranous glomerulopathy. We have here this glomerulus in the middle of the section, and we here have another one. And the glomeruli is observed for thickening of the basement membrane, like here and everywhere. And actually, in every segment, we notice that the glomerular basement membrane was thickened, and no increase in the mesangial matrix or mesangial cells. This is the silver staining that highlight the second basement membrane. Also, it highlights the double contour. We can here show that is the basement membrane have two outlines, outer outline and inner outline, and this is the tram track appearance or double contour of the thickened basement membrane. This is immunofluorescence of IgG, and show diffuse high staining pattern of immunofluorescence for IgG, that the whole shaft is remarkable staining at the maximum staining intensity for IgG. This is higher magnification, and here we can show the two. This is outer basement membrane, and this is the inner basement membrane of the second glomerular basement membrane. Now we'll shift to the pathology of acute nephritic syndrome. And also we have many histological pattern involved in this category. The group here to be presented in this lecture, also we have membranoproliferative glomerulonephritis that could be presented as nephritic and also could be presented in the previous group of nephrotic. So MPGN could be presented with nephrotic or nephritic. Second item, we have acute post-infectious glomerulonephritis, and this is post-infectious is an old name. The most common usually updated name is acute diffuse proliferative GN. IgA could be presented by nephritic syndrome. And here the group of secondary or systemic diseases like systemic lupus erythematosus, and lastly that could be presented by acute nephritic syndrome, the rapidly progressive glomerulonephritis or the crescentic glomerulonephritis. And in this group we have three items: anti-GBM, immune complex glomerulonephritis, and the post-immune glomerulonephritis. MPGN, the pathological alteration, now we have more complication in the morphology or the glomerular involvement. First, we have in the minimal change, no abnormality. In the FSGS, we have just mesangial expansion, and in the membranous, we have thickened basement membrane. Now we have more complex abnormal pattern in the glomeruli, and here we have pathologic alteration of both mesangium and the peripheral glomerular capillary walls. The changes tend to be diffuse or global, but in mild disease, it is more focal and segmental. Glomeruli often display accentuation of lobulation, as we can describe here in this image. This is a glomerulus here, and it showed accentuation of lobulation by means of segmentation. Like here, this is a segment, and this is another segment, and here another segment, and there are a lot, in spite of one integrated capillary tuft as one segment. No, here we have accentuation of lobulation. Also, we have mesangial expansion here, like highlighted in this pink color. So we have accentuated lobulation, mesangial expansion, hypercellularity, marked increase in the number of cells inside the glomerulus, which are mesangial and endocapillary. Besides this, we have thickened basement membrane. This thickened basement membrane and the mesangial expansion causes encroachment on the capillary luminal area that we are noticing here. This is a narrowed capillary, narrowed, and some about to be obliterated and very narrow, like here and here. And this is usually associated with hypertension, the cause of narrowing or encroaching on the capillary lumen. Second category in the nephritic group is the post-infectious glomerulonephritis or acute diffuse proliferative glomerulonephritis. Post-infectious glomerulonephritis or acute diffuse proliferative is caused by acute, usually self-limited infection, in which case the term post-streptococcal glomerulonephritis. It is characterized by numerous neutrophils, and here the term acute because the presence of neutrophils. Endocapillary hypercellularity, so the term proliferative, affecting all glomeruli. It is diffuse. Eosinophils may be present and are contributed to endocapillary hypercellularity. In this figure, we have here, this is the capillary lumina, and in all the segment we observed for intracapillary presence of leukocyte or neutrophils inside the capillary lumen, and this is the endocapillary hypercellularity. Is associated with red blood cell cast, and this shows patient exhibiting hematuria. In the course of post-infections, first there is a loss of neutrophils and opening of the lumen. that was engorgement and occluded by numerous number of neutrophils that have been narrowed by endocapillary hypercellularity and leukocyte influx. Second 2 weeks, 75% in the first 2 weeks of the course, most of the endocapillary hypercellularity was composed of neutrophils, 75%. Through a period of 3 to 4 weeks, the neutrophils reduced in number into 20%. After 6 weeks, no non-neutrophils, and here the course of this disease is self-limited. As the neutrophil disappear, the complex endocapillary hypercellularity simplifies to pure mesangial hypercellularity with variable mesangial matrix increase that may persist for several years. Most patients, finally, the glomeruli recovers their normal histology, and most destructive inflammatory lesions evolve into focal segmental patches of sclerosis, and this is a healing stage. Active glomerular inflammation persists longer than 6 months, raises the possibility of infection other than post-infectious glomerulonephritis, because this condition have a self-limited and short course. The second item in the nephritic group is the IgE nephropathy. IgE nephropathy is a glomerular disease in which glomerular immunostaining for IgE, this disease diagnosed by immunofluorescence. So we should have glomerular immunostaining for IgA more intense or equal intense as staining for IgG and IgM, except in patients with SLE, in which the dominant or codominant IgA staining is considered to be lupus nephritis with extensive IgA nephropathy. This glomerulus here exhibited in this segment, we have mesangial expansion associated with segmental mesangial hypercellularity. Here, the hypercellularity resulting from the mesangial cells, but the capillary, no inflammatory cells inside, and the capillary here looks normal, and there is no thickened basement membrane, just only segmental mesangial expansion and hypercellular, and this is typical picture or typical pattern of IgA nephropathy. This is the immunofluorescence, and we notice here for IgA, this is staining for IgA, and here we notice that moderate to strong staining and at the mesangial. Here the staining for IgA is the mesangial side, no staining at the peripheral capillary wall, just staining is restricted to the mesangial area. Now we'll shift it to the next item of nephritic syndrome or acute nephritis presented. This is systemic lupus erythematosus. Lupus is a systemic autoimmune disease that affects multiple organs, including skin, joint, kidney, serous membranes, lung, and central nervous system. And this is the old classification by WHO that involved here the 5 classes of lupus nephritis. Class 1, normal glomerulus by light microscope, immunofluorescence, and EM. Class 2, purely mesangial disease, looks like IgE, normociliary mesangium or mesangial deposit by immunofluorescence and or EM. Mesangial hypercellularity, mesangial deposit by immunofluorescence and or EM. Class 3 is the focal proliferative GN with less than 50% affection of the glomeruli. Class 4 is like class 3 proliferative GN, but it is diffuse, involved more than 50% of the glomeruli. And the class 5 is the membranous glomerulopathy class. The working classification that we use now in pathology lab for classifying lupus nephritis at the renal biopsy, we utilize the ISN classification, Renal Pathology Society, that published 2003, that published at the year 2004. And we have here class 1, minimal mesangial lupus nephritis, very minimal or normal looking renal biopsy. For class 2, it is mesangial proliferative lupus nephritis mimicking IgA nephropathy. Class 3 and 4 is the lupus nephritis proliferative. For class 3, it is focal, and class 4, it is diffuse. Class 5, the membranous lupus glomerulopathy. And the class 6, advanced sclerosing lupus nephritis with more than 90% of the nephron involved were globally sclerosed. And this is a stage of end-stage renal disease. Glomerular pathology, according to ISN classification, class 1, minimal mesangial lupus nephritis. And here, this looking like minimal change disease and no immunofluorescence or EM abnormality. For class 2, just we have segmental mesangial expansion associated with minor mesangial hypercellularity, like here and here. Then this is class 2. Class 3, focal lupus nephritis, and the class 4, diffuse lupus nephritis. The glomerular lesion of class 3 and class 4 lupus nephritis are qualitatively similar, differing only in severity and distribution. Definition of class 3 lupus nephritis is a focal segmental or global endocapillary proliferative GN affecting less than 50% of the total glomeruli sample. Class 4 lupus nephritis diffuse segmental or global endocapillary proliferative GN affecting more than 50% of the glomeruli. And here, this is lupus nephritis class 3. We have in this photo, we have show that this segment of the glomerulus have patent glomeruli, no thickened basement membrane, no mesangial expansion, no hypercellularity. But here in this segment, it is markedly affecting, have mesangial expansion, mesangial hypercellularity with increase in number of mesangial and endothelial cells, and we have endocapillary inflammatory cells with neutrophils here and here and here. And in this segment, we have the severest lesion that could occur in a glomeruli, which is fibrinoid necrosis, or this is a sort of vasculitis. Here in the fibrinoid necrosis, this is severe nephritis, have multiple lesion of the lupus nephritis, mesangial expansion, hypercellularity, endocapillary leukocytic oxidate, and fibrinoid necrosis with karyopyxis or fragmented nuclei of the mesangial cells. This is a case of class 3 or class 4 lupus nephritis. That is, here have fibrinoid change with fibrin oxidation and early crescent formation. That is here the very nice finding. This is staining for fibrinogen that we after we occurring of fibrinoid change and elaboration of fibrin. An early or starting crescent formation. This is a nice photo for a case of lupus nephritis class 4. And this glomeruli is hugely remarkable for pathology. He is very clear. Here is a wire loop lesion or huge thickening of the basement membrane and immune deposit that is appear at the light microscope. Here the mesangial texture is replaced by immune deposit, and this is wire loop lesion, and here is the wire loop lesion that distributed elsewhere, and here is the mesangial expansion and mesangial hypercellularity. Here is huge mesangial expansion that's encroaching the capillary area and occluding and or obliterating the capillary lumina. Also here is mesangial proliferation or hypercellularity. And here we have hyaline thrombi, intracapillary thrombi. This is also another case of lupus nephritis class 4. And the glomeruli is remarkably altered histology, completely different. We have here huge mesangial expansion and hypercellularity. This area, the capillary lumina, like here, it's completely encroaching. That's nearly occluded by the mesangial expansion and the hypercellularity, and here hyaline thrombi. And at this segment, we have cellular crescent also involved from here up to here. This is cellular crescent. And here, this case of class 4 lupus nephritis, and this is the immunofluorescence for the complement tree, and we have large masses or lumpy masses that distributed all everywhere in the glomerular mesangial and subendothelial and subepithelial site, and this is coarse granular deposit for complement number 3. And this is another case stained for IgG and also have diffusely distributed immunoglobulin G deposit along the capillary wall and the mesangium and subendothelial and subepithelial. And we show here the cross subendothelial lesion and here, and this is the mesangial or capillary wall lesion. Class 4 lupus nephritis or nephropathy is for membranous nephropathy, and as described before in the nephrotic syndrome, the only abnormality for the membranes is just thickening of the basement membrane by a subepithelial deposit, and this will be highlighted in the lecture of electron microscopy. And here, this is a photo of a case of class 5 lupus nephritis nephropathy, and we have just thickened basement membrane, not associated with mesangial alteration or hypercellularity. And this is a silver stain showing the thickened basement membrane, not associated with mesangial expansion or any other glomerular alteration. Here is a thickened basement membrane highlighted by the silver stain. Next class after nephrotic and nephritic, this is a group of acute renal failure. And here lies example of ANCA disease, vasculitis, non-ANCA, thrombotic macroangiopathies, diseases affecting endothelium, hypertensive renal disease, and thrombotic and embolic diseases. And here in this photo, this is a section in a glomerulus, and the glomerulus here is studied for a huge circumferential crescent. Here is the boundary or the Bowman's capsule, and all these cells are cells of cellular crescent, and the tuft, the glomerular tuft, is just restricted here to this segment. And in this tuft, we notice here is a focal segmental necrotizing glomerulonephritis, and this is a very clear example for ANCA-associated glomerulonephritis with focal necrotizing glomerulonephritis and the huge cellular crescent obliterating the capillary tuft. The next group of chronic renal failure, we have hypertensive renal vascular disease. And here we have example of hypertensive patient. This glomerulus here is showing normal morphology. We have no glomerular alteration, but we have here this artery is remarkable for myofibrointimal proliferation, and thus here we consider here this segment is considered this segment normal. We have the onion skin or smooth muscle proliferation here and here, and associated with fibroedematous or intimal fibrosis. And this is example of a hypertensive vascular disease. And the second most common item in this group of chronic renal failure, and this is the most two common causes of chronic renal failure, the hypertensive renal vascular disease and the diabetic nephropathy. The most important glomerular region for diabetes, we have capillary basement membrane thickening, diffuse mesangial sclerosis, or nodular glomerulosclerosis, that is known as Kimley-Steil-Wilson nodules. The glomerular capillary basement membrane are thickened throughout their entire length. And here we have an example of nodular glomerulosclerosis. This is the nodular of Kimley-Steil-Wilson nodule. This is the mesangial nodular sclerosis of diabetic glomerulosclerosis. Kimley-Steil-Wilson lesion, ball-like deposit of laminated matrix situated in the periphery of the glomerulus contained trapped mesangial cells, like here and here. And here we have the capsular drop lesion of the diabetic, and the glomerular tuft here is subtotally sclerosed, and we call for this an obsolescent glomerulus with the hyaline cap and capsular drop lesion. Renal atherosclerosis and arteriosclerosis of diabetic nephropathy. Here the afferent arteriole, and this is studied for nodular hyaline change, and this is another small artery and is studied for nodular or diffuse hyaline change, and this is classic diabetic nephropathy. And I thank you for this.